Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is exercise and physical activity in cancer survivorship, and our guest is Dr. Jess Gorzelitz. Welcome, Jess. Jess is assistant professor at the University of Iowa. She's in the Department of Health, Sport, and Human Physiology, and she's also the director of the Physical Activity and Cancer Survivorship Lab. So welcome to our program, and thanks for being our guest.
Thanks so much, Dr. Deming. It's great to be back.
So I'm really looking forward to our talk. But before we get into the talk and the subject, tell us a little bit about yourself. Where did you grow up?
Yeah, so I'm from the Midwest. I'm originally from northeastern Wisconsin. I did all of my training, all three of my degrees at the University of Wisconsin, where I trained in both exercise science and epidemiology. After then, I went to the National Cancer Institute to hone my epidemiologic skills and to learn more about big data. And I've brought those skills to the University of Iowa over here on the east side of the state.
So let's go back to before college. So what was the town that you grew up in and went to high school in?
Yeah, I'm from Appleton, Wisconsin. So it's the stone's throw from Green Bay, the home of the greatest football franchise in the league.
And how many in your graduating class in high school?
Oh, so I went to a small Catholic high school. I think we had maybe 100 in my
Oh,
class.
okay. And here's the big question. What was your claim to fame in high school?
Oh my gosh. I was captain of the math league for 3 years.
Okay. All right.
Yeah.
And
Not the flex you would think it is, but I I led the development of shirts, that we could all wear with pride, which they were not very exciting.
and were you involved in sports in high school?
Oh yeah. So I grew up weightlifting with my dad. I loved playing basketball. I still do. And he's the one that got me to bite on the exercise bug. So growing up, resistance exercise was a form of strength conditioning to serve the basketball goals. Of course, the basketball dreams didn't work out for me. It was a lot of fun, but I still kept the strength conditioning sort of resistance training part going forward.
And then when you went to the University of Wisconsin and you're entering your first year of undergrad, what was your first declared major as you started college?
Oh my gosh, I think I was a biology major.
Okay.
Yeah, I
And
like science and yeah.
and then what did you ended up, I think, in kinesiology as
That's
your undergrad major?
Yeah, that's correct. I hung out, I lived in the dorms, like a lot of college students do, and we would go together as a group to lift and hang out in the weight room. And it was there interfacing with other students who were training or working in the weight room that I learned that kinesiology was a major. And it was great to sort of attach the science, the adaptation, the physiology to the things that I had done growing up, the things that my dad would tell me to do. There's an actual science to it. And that was great for me.
And so as you switched over to kinesiology, did you ever have in mind that you would end up getting a PhD, or did you think that that was going to be on a track to go to physical therapy or athletic training, or you just embraced it as a pure science?
Yeah, so that I can't make this joke with my students because it dates me, but growing up, my mom was obsessed with ER. She's a big George Clooney fan. So and now even Grey's Anatomy is a dated reference, so it's fine. But I liked math and science, so I thought I would be a physician. Um, and I didn't like the prereqs. I had a really hard time with the all the coursework and the expectations and trying to have a life. So for me, I just kept sticking to the exercise thing. I knew I liked this, so I figured I would get this degree and then see what would be next.
And so then you stayed at the University of Wisconsin and got your master's, and that was in epidemiology. Is that right?
Yeah, and it seems like a weird switch. So for me, when I was in undergrad, I figured out I was a kinesthetic learner. I needed to do the thing in order to understand it. So I was working as a personal trainer for, rent money or fund money. And I really liked that individual behavior change where you got to know a person, understand their barriers, and teach them the sort of biomechanics, the adaptation. But it was really draining to do that one on one. At most, I could only see so many people in a week. And looking at the population data, there has to be 100,000 of me, and it just didn't make sense. So I knew I wanted to get more education, and I thought epidemiology could be the way to understand population level inference and how do we take what we see on an individual scale to understand that en masse?
And then you weren't done with your master's. You went on, stayed there at the University of Wisconsin, and got your PhD. At the time that you got your PhD, it was still in the Department of Kinesiology. Was that a new thing? It, I'm quite a bit older than you. When I attended college. The idea of getting a PhD in kinesiology, I don't think they'd thought of that yet. So I was just curious the background of a PhD in kinesiology, and did you have a mentor there at the University of Wisconsin? And I imagine you had to figure out what you're going to do your thesis on and research and
Yeah, precisely, Dr. Deming. That's what it was. Undergrad, I was exercise science. Grad work, I was epidemiology. The PhD was meant to sort of combine them. And actually, my specialization is in physical activity epidemiology. So it marries the two. Our department has been or at the time had a pretty solid reputation for a couple decades before, but you could say it was an emerging field. And finding a mentor for me, it was really important that we could study exercise and physical activity in cancer survivors instead of it just being a non-specific population. So I was able to find a mentor who had that expertise. Thankfully, had just joined the university, so I didn't have to leave. So
and a big cancer center there at the University of Wisconsin, Madison, the Carbone Cancer Center, one of the NCI designated cancer centers. So you had some mentorship or support, or at least collaboration with the cancer center as you were doing your PhD.
Yeah, great mentorship. My PhD advisor was a full member and really active in the cancer epidemiology program there.
And then postdoc, you got to go to the DC area, the NIH. And I actually, when I finished my residency, I did my first 2 years at the National Cancer Institute and lived in Bethesda. And so you were in which division of the NIH?
So within NCI, I was in the Division of Cancer Epidemiology and Genetics, or commonly it's referred to as the Intramural Research Program. The federal agencies like the National Cancer Institute have this sort of extramural facing where they interface with the public, manage grant portfolios, and then they have the intramural program, which I was a member, where it sort of looks like an academic department. They have individual investigators who are meant to do research, publish original data, launch their own studies in a more academic environment.
And your PhD, you dealt with endometrial cancer survivors, I think, if I read. And then did you continue to do additional work with that group of patients at NIH, or what was your work there as a postdoc?
Yeah, it's a good question. It was a completely different approach. So while I was at the NCI, I was focused on developing new skills in epidemiology. So it was not specific to a patient population. This is a little particular, but one of the skills I worked on was molecular epidemiology, or looking at some of the blood-based biomarkers, ideally to explore the way that we could measure response to exercise using previously collected data. But the main way I spent my time was using observational data that had already been collected to look at unique exposures of resistance training and aerobic exercise on cancer relevant outcomes like recurrence and mortality, not specific to any specific type of cancer.
Mm-hmm. Well, let's shift now and talk about your work there at the University of Iowa. And I think you've been there since was it 2022 that you came
2022.
to the University of Iowa, another NCI designated comprehensive cancer center. Were you the first in this field to come to the University of Iowa, or was there already a program looking at with PhDs in exercise and cancer?
Yeah, it's a good question. At the time I was hired, I was the only PhD in exercise science and cancer. I'm in a department of health, sport, and human physiology. So the expertise of my close department is more vascular. It's more cardiovascular and physiologic in nature. However, at the cancer center and in different departments like the College of Epidemiology or the College of Public Health, the Department of Epidemiology, and a lot of research and clinical faculty, there was a growing interest in survivorship and figuring out how to use exercise as an intervention or as a supportive care, leverage the existing expertise at BU.
And it's really kind of taken off in the last 5 years. Many more papers is becoming more common. As you know, we have a program here in Central Iowa called Above and Beyond Cancer. It's 15 years old. We actually started doing physical activity stuff here at the Mercy One Health and Fitness Center about 16 years ago. And at that time, we called it Live Strong at the Y. And so
Mhm.
I kind of think of this the general public learning about physical activity as an important component of health and fitness, but specifically related to cancer. So I kind of give Lance Armstrong, no matter what he did or what drugs he did, some credit for not only destigmatizing cancer and elevating the position of cancer survivorship, but specifically this idea of physical activity as part of an important component of the cancer journey.
I totally agree, and I think it's interesting to learn how the field has evolved. You know, specifically within exercise oncology, it's a relatively new discipline. You know, it hasn't been, it's not even 50 years old yet, but some of the landmark studies are starting to come out in the 1970s. However, you know, when I used to talk to my grandma, she would call cancer, you know, the big C. You didn't talk about it, and the mentality was, you know, you have to rest and recover. You know, you need to really store your energy for the journey, which is very different, you know, than the messaging that patients and survivors are getting today, which I think reflects the growing body of evidence.
Right. So, I graduated from medical school in 1980, and I've been in practice here in Des Moines for 36 years, but the common way is, "Oh, I'm so sorry you have cancer. Take it easy, take naps, eat bonbons." People baked you cookies. They brought over lots of casseroles for your freezer, and especially in the population of women with breast cancer who kind of get thrown into menopause as part of their cancer treatment. I mean, 80% of them would gain 20 pounds. They start on the cancer journey treadmill only having an abnormal mammogram and no symptoms, and they come off the treadmill having gone through chemotherapy and surgery and radiation and anti-estrogen, much less physically strong than they were at the beginning. And part of it was the messaging that they were getting from the cancer world, is to take it easy. So as you got involved, did you so was Live Strong a thing on the campus at the University of Wisconsin at the Carbone Cancer Center, or how did you see uh, patients embracing, or how did you encourage patients? First, you had to study, were they exercising or not, and what the impact was. Tell us about maybe your first study as you were trying to address real patients on the campus of the University of Wisconsin as it relates to physical activity and cancer.
Yeah, it's a great question. The Livestrong program is always near and dear to my heart as part of, you know, my dissertation research. You know, PhD students have to go through something called a comprehensive exam where are the exam is comprehensive. So your examiners can ask you anything, and you basically have to prove competency to move forward. And I bring this up because one of the questions on my exam was I had to review a paper about the Livestrong program and critique it. Pros and cons, you know, is this a valid study design? What did the Livestrong program evaluate? You know, what are the outcomes there? So that's always like very close to my heart. At the University of Wisconsin-Madison, it's similar to the Cancer Center here at the University of Iowa, where it functions as a matrix cancer center. So the researchers and the academic units are not necessarily embedded. There's not a building for cancer. There are different units that sort of create this overarching theme of the comprehensive cancer center. So for us, the first involvement I had with a trial or an intervention to work with patients was a study that my advisor was leading at the time. She had a career development award from the National Cancer Institute studying physical activity versus sedentary behavior versus the combination to look at health outcomes in breast cancer survivors. And that was a great opportunity for me to get involved as a graduate student. All I had to do was perform. I didn't have to necessarily, create a new question. But it was really fascinating. At the time, that was a really novel question, looking at physical activity as an intervention and sedentary behavior reduction, or the combination of the two for health outcomes. One of the things I got to do as the graduate research assistant is we would bring these, the Veridesks, the adjustable desks. We would go drop them off to patients' homes or their offices. So myself and a fellow grad student, I was the muscle. I would carry it, she would ring the doorbell, and we'd install it, and then have to go pick it up after 12 weeks. So it was a really good entrance point, and of course the participants were beautiful and wonderful and gregarious, and it was a great first experience.
And that particular study, was the patient population in the midst of getting chemotherapy, or were they after their surgery, chemotherapy, radiation, and perhaps many of them were getting oral antiestrogens?
Great question. It was the latter. So we oftentimes, we still do that. When we think about survivorship studies, we're targeting folks who have completed their primary treatment, and they may be on maintenance therapies or aromatase inhibitors or other hormonal treatments, but they had completed chemotherapy and surgery. We looked for a lag of 6 to 10 weeks before intervening for any sort of surgical limitations to make sure that we're not exacerbating any, wounds or anything like that.
And at your time there at Wisconsin, were you able to see that study through completion into publication?
I was able to see the study to completion. It's a great mentoring structure to see, or a great, leadership structure to help execute, right? Like, to really appreciate how much work goes into one individual study that, for lack of a better word, will sit on a shelf that then creates the evidence that forms the guidelines. So it gives a person really great respect for the scientific enterprise and the rigor and reproducibility of the work we need to do.
Mm-hmm. And what did that study demonstrate?
So that study, to my knowledge, is not yet published, but I do believe that the sedentary and physical activity group combination was better than the no treatment control for behavioral outcomes, and I think for some metabolic outcomes as well.
Okay. So let me just invite you to give us a little bit of a primer on the relationship between exercise and cancer. So just invite you to think of us as students for a few minutes here, and tell us why exercise is important, and maybe we talk about invite you to talk about prevention of cancer, exercise during the treatment of cancer, and then obviously your specialty, exercise as part of survivorship.
Totally. And I apologize. I think I'm lagging a little bit here and there. So I apologize if I'm not syncing up. But for me, it's I've been flipping back and forth with language purposefully and sometimes accidentally. So thinking about the relationship between exercise and cancer, it's important to talk about the main characters. So we have physical activity, which is voluntary energy expenditure, something that moves your body, oftentimes as part of daily living. So for me, going out to get the mail is a great example of physical activity. Going out to get the mail at the mailbox is not exercise, though. For me, it's not planned, purposeful, or with any sort of fitness or physiologic benefit. So while all exercise is physical activity, not all physical activity is exercise. When we think about exercise, we are thinking about those intentional, physiologically taxing movements that are meant to reap a fitness benefit. And the two types of exercise that we have the best evidence for the relationship of exercise and cancer, the first is aerobic activity or aerobic exercise. Those are, like Dr. Deming, your spin class, the activities that get your heart rate up, cause you to sweat a little bit, do a little bit of heavy breathing. And then we have resistance exercise. So those are those exercises that tax the musculoskeletal system. Oftentimes we're holding or using an external force, but sometimes we can use body weight. These are things like weight training, strength machines, or free weight exercises as well. So in 2019, we actually had one of our landmark studies, two landmark studies published, where researchers looked at the association of physical activity. So again, that total movement throughout our day, and the prevention of cancer. So they were able to look across almost 1 million participants and pooling exposures or pooling data from multiple types of studies. And with that publication in 2019, this international expert consensus roundtable report indicated that physical activity was associated with a lower risk of developing 8 types of cancer. Of note, the flip side, they show that physical activity was associated with a higher risk of developing melanoma, which also makes a lot of sense on face validity. We know that people who are physically active, especially when we're thinking about aerobic exercise as part of that physical activity, they're more likely to be outside, maybe biking, maybe swimming there. So people want to know why. What is the case? What is the mechanism driving that? And there are a lot of researchers who are exploring these relationships and these mechanisms. There's a few that we're pretty confident on. So for example, the immune system. We know that exercise helps upregulate or support the immune system. And the immune system itself is responsible for destroying some of the naturally occurring errors or carcinogenic tumors that we have naturally in our body as a part of mitosis. So exercise improves the immune system. So that is one of the ways we can supercharge our cancer fighting pathways that we have built in. Other things we think about adiposity and body mass index. We know that people with excess body fat that can independently feed cancer cells that can occur. So perhaps that relationship is that physical activity reduces adiposity. And then through that, we are reducing the risk of cancer. Additionally, related to that mechanism, another one to note is the hormonal signaling pathway. We know that cancer is by definition unregulated cell growth, just cells that grow out of control, and it's really hard to stop them. When I talk to my students about cancer, I use the metaphor of a zombie apocalypse. You know, once a zombie is out of the cage, it can infect and mutate lots of humans. When you think about those cancer cells, we have those natural processes that catch them and make them become apoptotic or just get rid of them. If they become unregulated, continue to replicate and continue to grow, that's when we have a problem. So mechanisms that cause those cells to continue to grow, like hormones or other growth signaling pathways, that's a way that cancer continues to proliferate. We know that physical activity and exercise is associated with improvements in sort of regulating those growth pathways. So that's one of the ways that we can control cancer. That's just a brief overview of the mechanisms of physical and prevention. Where the field is right now is using exercise both in the treatment phase, so proper exercise oncology. Think about going for a run right after a chemo infusion, for example. My bailiwick is that survivorship phase when folks have completed their primary treatment. And my focus is on the health promotion, behavioral, long-term sequelae, and how physical activity and exercise can not only improve the physical, but also the psychological outcomes as well.
Yeah. And so I always tell my patients that the physical activity exercise is a reward in and of itself, and that even if it didn't affect your survivorship, even if it didn't reduce your risk of getting another cancer, it has so many health benefits that it's good for your quality of life. It's good for your life. But we're now actually getting some studies that show that not only does it improve quality of life and all sorts of other health benefits, but let's talk about the recent New England Journal of Medicine article on exercise in patients who have been treated for stage 3 uh, colon cancer. So maybe I'll let you describe that study and the results.
Yeah, so this is called the Challenge Trial, and this was an international multi-site trial of stage 3 colorectal cancer and patients who had high risk stage 2. So in this patient population, without like standard of care, I think it's anywhere between 20 and 40% of patients will recur during that early surveillance period, so that 5 years post diagnosis. So this is it's a really huge public health threat, right? Folks find this disease, they treat this disease, but it's an excruciating process, not knowing, is your disease going to come back? What can you do to control it? We know that our intestines are very vital to digestion and overall experience. So in terms of treatment and patient need, this is a very significant study. And we know that for both men and women, colorectal cancer is one of the 3 most common cancers. And in young folks in particular, this is increasing in incidence over time. So through this approach, like I said, it was across multiple nations and multiple sites. They randomized about 900 people, men and women, to either receive the control group, which was health education. So these folks received information about healthy lifestyles, sun safety, diet, and physical activity, compared to the intervention group, which was a phased aerobic intervention. So as part of this,
Jess, can I interrupt for just a second? So
okay,
the other part that the audience should know is all of the patients had surgery and
right,
all of the patients had chemotherapy. So
correct,
they already had surgery, they already had chemotherapy, and they were thought to be cancer free at the end of that treatment. But as you pointed out, because there is a pretty high risk that 20 to 40% might recur, that's where the randomization happened. So everybody had
correct.
surgery, everybody had chemotherapy, and then half of them had a regimented exercise program, and the other half had some health education. Was
Yes, they called it the health education as the control
Okay,
group.
I'll let you take it from there, but I wanted
No,
everybody to know that all of these patients did have surgery and chemotherapy.
correct. Correct. And that's in the proper name of the title, right? Like we colloquially call it the challenge trial, but the name I think is a structured exercise program for folks with colon cancer following chemotherapy, surgery and chemotherapy. So I think it's an important distinction. And from an intervention delivery perspective, given the fact that they're in that active surveillance period, these folks are very engaged, right? Like you said, Dr. Deming, they had completed their primary treatment, but there is a lot of engagement. What is the outcome going to be? So for the exercise group, the intervention group, they received aerobic counseling, aerobic sessions, and this was phased over a 3-year period. So folks would come in and meet individually with a coach, and then they transition to remote checkups and follow-ups over a 3-year period. And so in this study design, it is the strongest design that we have scientifically. And I pointed this out to my students. This study started in 2007. So this takes decades and millions of dollars to execute. But it is worth it because it is the highest level of evidence that we can generate. Through randomization, it's a really powerful tool where we reduce a lot of the factors that are associated with other predictors of interest. So, for example, people who exercise are different than people who don't want to exercise. But if you force it, if you use a coin, that helps balances out things like body mass index, socioeconomic status, distance to treatment center, those types of factors. So, over their decade of follow up, they found they measured their primary outcome, which was progression free survival, which clinically is the more meaningful outcome here. This is harder to demonstrate. It's thinking about the way that we can use exercise to control cancer. survival, we all care about, right? We all want to live. But the progression-free aspect here indicates that the disease did not progress. It did not get worse. So over the course of the study, they were able to demonstrate a statistically significant, which means it's important. I think it was a 6.3% difference between groups, such that those who exercised, or who received the exercise group rather, they had a 6.3% better chance of progression-free survival, which I think is huge. They additionally measured overall survival comparing the groups. That effect size was larger. It was 7.4% higher for the folks in the exercise group versus the control.
Right. So very good evidence that an exercise program after chemotherapy and surgery for colon cancer improves survival. And did they also study quality of life issues? Was that a secondary looking at quality of life between the two groups?
I think that was one of the secondary outcomes. I will say, I think it was published on Monday of this week. They published some of the behavioral drivers
Oh,
as
okay.
well. And they showed that the intervention indeed targeted some of the behavioral pathways such as the social cognitive theory and self-efficacy. They were able to show that was able to change as well. But the top line is progression-free survival. I'm pretty sure health-related quality of life also had a
Mhm.
statistically significant improvement.
Yeah, I mean, in and of itself, that number one thing is just so important. I wonder, and I'm sure that we can dig into the paper and the follow-up papers, whether the individuals maintained exercise on their own after the 3 years of structured exercise ended.
Yeah, so I think based on the findings, they were able to do a 3-year follow-up period. I'd be curious to see what they're doing in terms of longer term follow-up. For our studies, or for the field, a 3-year follow-up is enormous. That is a really long period. Generally, most of these studies will look at weeks, if not months, of follow-up. You could argue that after 3 years, you have made a sustained behavior change.
Mhm. And we also have some other papers that have looked at survivorship, and I think there's at least a couple that look at it in breast cancer.
Mhm.
Probably not as rigorous a study as this one was, but maybe review for us the literature around exercise in breast cancer survivors.
Mhm. So breast cancer. So the strongest evidence we have for cancer type, we have currently it's breast, prostate, and now colon following the challenge trial here. Breast cancer is, I don't want to say great to study because that sounds wrong, but from a data perspective, it's the most prevalent cancer in women. Over the past decade, we've seen improvements in 5-year survival jump to above 90% for all stages, which is tremendous, really shows the improvements in the biomedical pathway and screening. So it's pretty common. It's easy to detect with regular mammography, and the treatments have improved. This high prevalence population allows us to really have the best evidence here to show that exercise is associated with a lower risk of recurrence for some molecular subtypes. We also have seen from observational data, which is currently rated at the strongest level, that breast cancer survivors who are physically active after a diagnosis have a lower risk of mortality. Of course, this challenge trial in colon cancer has not been replicated in breast cancer. But from the observational data, we are able to show pretty much as strongly as we can. The other thing I will add with respect to breast cancer is some of the emerging work in the field. So the National Cancer Institute, within the last 5 years, has put out a call to better understand some of these emerging questions in the field. So it's called the INICTO initiative. It's exercise and nutrition to improve, that's the I, clinical treatment outcomes in cancer. So the question is, can you use exercise in combination with standard first line therapy to improve some of the clinical outcomes? So, for example, there's a study that led by Dr. Katie Schmitz and Jennifer Ligabell at Dana-Farber, and they want to know, can you use resistance exercise to improve someone's fitness and physiology? This is in elderly breast cancer survivors. Sorry, she used the term elder breast cancer survivors. I want to be clear. Can you use resistance exercise to improve vitality such that women can improve and complete their chemotherapy regimen? So it's sort of this way to fortify. The hypothesis is that using training to fortify the body, women are less tired, they're less likely to miss their chemo. Does it help to improve their adherence because we know chemotherapy is so effective? So there is this large national initiative to answer some of these questions as part of the INICTO initiative.
And it kind of seems like it's a parallel to surgical studies that have looked at using physical activity as a pre-habilitation before undergoing a large surgery. That if you can do the physical activity before surgery, you're more likely to successfully get through the surgery and have better outcomes. And so it's kind of a parallel. If we do the physical activity before, are you going to be able to more likely successfully complete your treatment regimen?
Precisely, because again, we know the therapy is effective, right? Chemotherapy, radiation, surgery, we know it works, but there are plenty of reasons why patients can't or have difficulties with completing. The hypothesis is that if we can use the right combination and the right timing of exercise, we make that treatment more effective.
And let me just ask you then to summarize maybe the data or the trials on prostate cancer. As you mentioned, breast cancer is a good cancer to study because there are so many women who've been diagnosed with breast cancer. So there's lots, large cohort you could assemble. Same thing holds true for prostate cancer in men. What does the science tell us about physical activity, exercise in prostate cancer?
Yeah, it's a great point. It's the same. Prostate is the most common cancer in men. And much like breast cancer, we have routine screening and recommendations for men to screen for prostate cancer. So that those two populations serve as the analog. What we know for prostate cancer is that we've seen in observational evidence, again, at the highest level of rigor, that we can say that men with prostate cancer who are physically active have a lower risk of dying from their prostate cancer. And that's the strongest evidence that we can find from an observational perspective. In terms of recurrence and controlling the disease, there's a lot of emerging work. A lot of it's coming out of Western Australia, where they're trying to better understand the therapeutic role of exercise, in particular with some of the standard treatments used for prostate cancer. So I talked before about the mechanisms that we know hormonal pathways are oftentimes growth signals, and that can cause cancer to grow and proliferate. So one of the standard treatments for prostate cancer is androgen deprivation therapy. And we know that androgens have a significant effect on a man's physiology and several reproductive organs. There is work coming out of Western Australia, trying to understand how exercise, in particular resistance exercise, can counteract some of the effects of androgen deprivation therapy to sort of help improve a man's experience and specifically his quality of life and functioning in multiple dimensions. There is other work mechanistically out of that group where they're trying to understand how specific doses of exercise in prostate cancer will control tumor burden or aggressive nature of the tumor cells.
Yeah, that's a good point. That was the question I was going to ask you because in individuals with advanced prostate cancer, and sometimes it doesn't have to be even that advanced that they might get recommended short course androgen deprivation with radiation. And, it's amazing the deleterious effect even 1 or 2 years of androgen deprivation therapy has. But then
Mm-hmm.
men with early stage 4, it's like a forever treatment. And many men may survive for a decade or more with constant, continuous androgen deprivation and the effects it has on bone, muscle, strength, stamina.
Yes.
Um, so it's a little bit like, okay, do they have the strength and stamina to do the exercise program? But the exercise program may give them more strength and stamina. It's kind of that, anybody who exercises know that you're feeling tired and run down. You go do a workout that consumes energy, but you actually feel better after the exercise. So that will be interesting to see whether physical activity can offset some of the really bad side effects of androgen deprivation therapy.
Yeah, precisely. And that's the paradox. We know, there have been meta-analyses of meta-analyses to your point, about cancer-related fatigue. And this isn't specific to a tumor type, but there have been multiple meta-analyses come out to show that exercise is the most superior non-pharmacologic therapy for treating fatigue. But if a person's ever had fatigue, it's so paradoxical, right? Like you said, like, I have to spend money to earn money. I have to exert all this effort to get it. And it takes a while for the training effect to occur, but it is extremely effective for treating a really common symptom following treatment.
Let me ask you the analog question that we just discussed with androgen deprivation therapy. It's not exactly an analog, but for many women with breast cancer, estrogen receptor positive breast cancer, they may be put on tamoxifen or an aromatase inhibitor, an anti-estrogen, if you will, for years, 5, 10 years. Are there studies looking at can exercise help mitigate or modulate the deleterious effects of being deprived estrogen?
Yeah, I think that is one of the aims of Dr. Jennifer Ligabell's study out of Dana-Farber. She has the BeFit Be Well trial, which I think is currently enrolling. It remains, so I do believe that is a question that's out in the field. It remains a question between the oncology and the physiology space, one of the tricky parts. Can a person or can a woman lay down lean muscle mass when they're postmenopausal? It's believed that estrogen may have a necessary facilitating approach there. But then again, hypertrophy and hyperplasia, or the growth or the recruitment of the muscles, is not the only way by which a person gets stronger. We know that adaptation can also occur with efficiency in motor neuron recruitment or the way that the brain talks to the periphery. So it is an interesting question, right? If a woman is on a known estrogen blocker, and we know that estrogen is needed for muscle growth, can a woman get stronger on this treatment? And believe it or not, these trials are really hard to do, not only from a side effect profile from the anti-estrogen therapies, but in recruiting and retaining enough women to study this in experimental fashion. Because we know as women age, that there are significant changes physiologically and loss of muscle, but strength and function predict longevity and mortality related outcomes. So it's a tricky line to walk, and it's an interesting question that remains in the field that is hard to assess pragmatically.
Well, Jess, I've got about 2 hours more questions, but I'm a generous guy, and so I'm going to give up the rest of the questions to the audience because we have a live studio audience here, and you've packed them in. And then we also have individuals watching us live streaming. If you're one of the individuals watching us live streaming, you can put your question to Dr. Gorzelitz in the comment section of the software you're using, but we're going to let the live studio audience get first shot. Ron, you get the microphone first.
Yeah, I was just curious, when you're recommending exercise for survivors, do you tailor it to certain types of cancers or certain types of treatments that people have received? Or is it just kind of a general exercise program that might just individually benefit that person?
Yeah, great question, Ron. So there's 3 ways to think about this. We have these national recommendations of the dose that all cancer survivors are supposed to do. And that's 2.5 hours a week of aerobic exercise and 2 days a week of strength training. That's the global recommendation for everybody. we know that recommendations work at a population level, not an individual one. So the standard practice is to tailor an exercise routine based not only on the individual's physiology, their fitness goals, and then considerations of their treatment. So for example, if a patient has an ostomy bag, they're not going to be doing, crunches or other abdominal compression activities with a lot of Valsalva maneuver. And that's certainly related to a person's treatment trajectory. The other part to consider as well are the behavioral antecedents. We can give people tailored exercise prescriptions. We could print them off and mail them to every person in the state. But the motivational and behavioral factors to get someone to do exercise vary substantially. And that sometimes is related to their cancer, but then also related to other factors of life.
Okay, great. Angelina, you get the next question.
Yes, tailing off a little bit of that. I've also realized, because I went through my FIT program when I was going through my treatment, and then afterwards working out after surgery and all that. It is challenging. But one thing I've learned from the neurologist physician I just saw yesterday was talking about how times we tend to lose a lot of muscle mass, and that we forget to take on protein. So do you introduce that or talk to patients about that's something to be aware of, and the types of proteins that would help that person's body as they exercise?
No, it's a great question, right? If you're training, if you're taxing the system, there has to be sufficient anabolic reserve, right? You have to have fuel in the tank in order to grow. For us, in our role scientifically, we are very clearly on the exercise side of things, and we want to be really mindful of our personal scope of practice. We're not dietitians or nutritionists in any capacity. That said, we will refer to professionals, like we've got dietetics in the hospital, and recommendations from the American Cancer Society regarding dietary choices. So we're happy to give recommendations from authoritative sources. And that also includes holistic diet, right? The American Cancer Society, in addition to certain lean protein choices, fruits and vegetables, right? Limiting alcohol, not smoking, all of those things go together in relationship with exercise as well.
Great. George?
Yeah, this is a question that some people still talk about. Reserving your strength for the fight against cancer. Are there some types of cancer, some stages of cancer where something should be held in reserve as opposed to, exercising and working out to improve outcomes? Or is exercise always the right thing to do in all cases?
To quote Star Wars, only a Sith deals in absolutes. So it feels like a tricky line to say always, everywhere, all the time, right? But it's, there is no one size fits all. I'm happy to talk about the epidemiology and the population and what we see in terms of evidence. But when we're looking at that evidence, we're looking at the totality of everything, right? For every rule, there is indeed an exception. I am not familiar with any literature that supports resting and reserving strength. The literature with which I am familiar is the importance of adapting a person's physiology using something called progressive overload. So I wouldn't tell anyone in the room to try to pick up 600 pounds right now off the floor. That doesn't make any sense. However, if a person is a strongman competitor, that's a warm-up set. That's not a lot of weight. So I think in terms of the relationship of exercise and health outcomes, it's always relative to the performance of the individual and making sure the adaptation is occurring safely.
Yeah, and just to emphasize, but you're not aware of any study where where they actually had worse outcomes because they exercised.
I'm personally not familiar. There are two things to consider. One, there's something called publication bias, right? If a person finds, like if I do a study and I find a bad outcome, we probably don't want to publish it. I'm not saying anyone has nefarious intent, but it's just the human condition, right? Like it's something to be mindful of that would be counterculture. The other thing to consider too with these studies, and like the challenge trial we were talking about, Dr. Deming, they measure something called adverse outcomes. So exercise actually puts people at risk for certain adverse outcomes like injuries. In the challenge trial, the exercise group had 18% higher rate of musculoskeletal injuries, which this can include things like turning an ankle, a bruise on the hip, falling down the stairs. These injuries occur due to exercise. To live is to be at risk. So the more a person moves, the more likely they are to have an injury. And we cover this in every one of our informed consent documents for our study. It's safest. The best way to not have an injury is to sleep all the time, to like not move at all. So it's a balance of that risk profile, right? Exercise is associated with a higher risk of injury, but doing so safely in a progressive format, often with a professional, can lower a person's risk.
Great. Other questions? We have another one over here. Great.
Well, I'm just kind of thinking of my own personal wimpiness going through some treatment where it's a tremendous effort just even walking much of a distance. So there is that aspect that it just feels so difficult.
And Ron, prior to your cancer and even through cancer, you've always been a very physically active person, engaging in vigorous physical activity. And you're saying that some of your chemo regimens, even for someone who has a mindset that they want to work through it, it's been difficult to rally the energy to get out there and.
Yeah, absolutely. I guess I'm just making a comment of that, of how difficult
let's see what Dr. Gorzelitz has to say.
It's a perfectly fair comment. I can relate this to the way we quantify physical activity and exercise. We talk about things in terms of absolute value and relative value. So an absolute value is like a 6. It's a 6 for everybody. 6 is a 6. But a relative expression of some of those units is, for me, this feels like 50% of my capacity. And that 50% capacity could be walking very slowly on a treadmill. For some people, that could be a full sprint. So it is really important when we're thinking about dosing and using exercise, the importance of relative exertion. Because again, on an absolute scale, it's really, some of these recommendations are absolute, right? Do this amount, do this amount. But where the relative portion comes in, takes into consideration the individual. If your lung capacity is down because you've lost an entire lobe following treatment, walking to the car is going to feel vigorous for you. And that is really important to consider when we're thinking about dosing and communicating and progressing exercise or even physical activity.
So you might, based on your own personal history of how well you can exercise and how much you can do, think that what you're doing doesn't count as exercise, but based on where you are physiologically, doing something that you might not even think is exercise really is exercise and can be beneficial. I think that's what I'm hearing you say.
Absolutely. And the thing well stated, the other thing I will add, we talk about guidelines and recommendations. There are guidelines for Americans and for cancer survivors alike. When the first round of these guidelines were published, now these are just physical activity guidelines for Americans for health outcomes. They were published in 2008, and they were very particular that you can only count physical activity if it's in 10-minute bouts. So if you did 4 minutes of physical activity, it doesn't count. They updated that guidance in 2018, and they dropped that requirement because the evidence was showing, and this is true for cancer as well, that every single minute matters, that this arbitrary sort of 10-minute restriction doesn't make sense biologically or physiologically. So in that spirit, not beating yourself up for not doing 30 minutes, 4 minutes is better than 0 minutes. Everything is relative.
Yeah, I would say that even climbing a flight of stairs that might take 2 minutes or 1 minute has some value.
We call it a dose response relationship, right?
Yeah.
So a little bit is better than 0. More is better. generally.
George, any questions from our studio audience or from our, okay. So we're going to wrap it up here. Dr. Jess Gorzelitz, thank you so much. Dr. Gorzelitz is a PhD, and she's at the University of Iowa, and she is the director of the exercise and physical activity. No, give me the right saying for your lab, Jess.
It's the Physical Activity and Cancer Survivorship Lab.
Physical Activity and Survivorship Lab, and is developing also a clinic for providing cancer survivors at the University of Iowa with a structured exercise program. And that's going to be starting later this year, right?
That's correct, Dr. Deming. Some of the questions from the audience today reflect some of the questions that patients have, right? There is a need for individual tailoring and support, depending on where a person is in their journey.
And I'm sorry we didn't get more into that aspect of what you're developing. So it'll all the reason to bring you back again and have you as a guest again.
I would be happy to.
So thanks again. Really appreciate you being our guest. If anyone watching this show tonight knows someone that would benefit by watching it and weren't able to be here tonight, good news. This program will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer Center website. Thanks for joining us. I hope you'll join us again next week. Thanks, everyone.